I'd like to introduce Dr. Alex Ryan. He is a global leader in systems transformation, known for his work in complex change, public sector innovation, and redesigning large-scale institutions. His career spans roles in government, health systems, and innovation labs. And he is widely recognized for helping organizations rethink how they deliver services in rapidly evolving environments. Graeme Kohler is the Senior Director of Nova Scotia Health, where he leads primary care transformation, chronic disease management, and community-based service redesign. His work focuses on improving access, strengthening patient-centered care, and creating the conditions for cross-sector collaboration that leads to better outcomes. In this session, they'll share insights on what meaningful system change looks like in practice, how cross-sector partnerships can drive better outcomes, and what other jurisdictions can learn from Nova Scotia's experience. Please settle in, and please join me in welcoming Dr. Alex Ryan and Graeme Kohler, presenting Rewiring Healthcare, Lessons from Nova Scotia's Health Beyond Hospital. Thank you for joining us.
Is this working? Hello, bonjour, Fredericton. I've had the privilege now of keynoting at GovMaker 3 times, but I'm particularly excited to be back this year because of this joining up of GovMaker with the open data. Also, because of all the transformation that's happening here in New Brunswick. You are a shining light in Canada right now. And thirdly, because I get to do this one with my client, Graeme Kohler. So I'd like to introduce Graeme. He is the Senior Director of Health Beyond Hospital. And Graeme, after a distinguished career, a couple of decades in primary health care, Graeme accepted this, this opportunity and challenge of leading Health Beyond Hospital. And it was the same week that Nick Scott, who needs no introduction in this room, he's low-key famous, and Nick Scott and I were contracted by Nova Scotia Health as the co-design consultants for the project. So I've gotten to know Graeme, and I always say Graeme is the dream client. He's the dream client because he has ambition, yet he's humble. He's a great listener and great team builder. Graeme is tolerant of risk and ambiguity, you know, Graeme's secret weapon is his mobile phone, because I think Graeme has at least half of the 40,000 Nova Scotia Health employees locked into that thing. And whenever we needed to get some impossible task done by close of business, somebody seemed to owe Graeme a favour, and he could get it done. So it's been a really great experience working with Graeme.
And I have the pleasure of introducing Dr. Alex Ryan. So Alex is the spiffy gentleman here to my left. And Alex is co-founder, along with his lovely wife Eleanor, of Synthetikos Incorporated. And obviously he's talked a bit about our relationship. Alex and Nick have been working with us as consultants on this work. Alex has many, many skills. He is a doctor of applied mathematics. And his work is focused on complex system redesign, which was super helpful for us because healthcare is a complex adaptive system, and we really leaned into that system design approach, which was led by Alex and Nick as well. Alex is a very spiffy dresser. You'll notice his really cool shirt that he has underneath. You should ask him later on about his Post-it note shirt, which is revolutionary, and he has a special skill in teaching people how to properly remove a Post-it note so that it won't curl up, so that you can take pictures and load it into AI. Based on the last year's, no, just kidding. So that we can use that as a generative tool for our work, and Alex is going to talk a little bit more about that. So Alex, over to you.
Great, and so I think we want to introduce a little bit of the team behind this as well.
Yeah, absolutely. So this is just a quick picture. This is from one of our co-design workshops. There's a team that Alex and Nick have been supporting along the journey. And so we have a project team that meets on a weekly basis, a really small group. We've got a core group that meets on a bi-weekly, now monthly basis. We just transitioned. That's about 60, 65 people. And then there's been about 300 to 400 people collectively that have been involved and or have led different portions of our work along the way. So this is just a smattering from one of our co-designs.
And Graeme, the question I want to start with is why is Nova Scotia Health completely redesigning the discharge from hospital experience, and why now?
Yeah, it's a really important question for Nova Scotia, and I'm so glad you asked me that, Alex. Like we didn't.
You're welcome, Graeme.
So, Health Beyond Hospital is, just as Alex said, it's really focused on helping patients get discharged from hospital so that they can get home as soon as they're medically fit. And then once they're home, the work is also helping to support patients to get the wraparound services that they need to stay in community so that they can continue to recover there, thrive, and live their best life, because nobody wants to stay longer than is possibly needed in a hospital. Because when you stay in a hospital longer than you need to, you are at risk. So hospitals are super important for us. We need them to be there, but we don't need to stay there longer than we ideally would stay. And the reason for that is because the longer that you stay, you're more at risk of getting hospital-acquired infections. You get deconditioned because you don't move around as much as you would if you were living at home. You're at a higher risk of fall because you get deconditioned. It can lead to delirium. There's all sorts of challenges. And so in Nova Scotia, there's about 3,000 hospital beds. And at any given time, there are 20% of those beds that are being occupied by patients who are alternate level of care, which means they're medically fit to be discharged, but there's a social barrier that's preventing them from going home. So effectively, there are 550 beds at any given time in our provincial health system that are effectively closed. So this is creating a challenge for us. So we're working to help solve that problem. And so some of the objectives, as you can see on the slide here, is we're helping to support patients get back to that place they call home so they can continue to recover there with support. We want to reduce that alternate level of care footprint so they're not in our hospitals longer than is needed. We want to help integrate health and social services. So this work is not just done by Nova Scotia Health. It's been a 6-way partnership that's been co-designed, an equal partnership across Nova Scotia Health and 5 government departments. So our Opportunities in Social Development, our Seniors and Long-Term Care, our Office of Addictions and Mental Health, Department of Health and Wellness, and EHS, our Provincial Health Service or Emergency Health Service Delivery Structure. And so all of this is being wrapped around within our care coordination model structure to help support patients with their operational model. So Alex, we've talked a little bit about what is Health Beyond Hospital. Could you tell us a little bit about how we've used this co-design approach to help set this work up for success?
Yeah, certainly. This is one for all the process nerds. Co-design was a really important approach for us to take on this project because of the complexity. This 6-way partnership, if anyone's tried to do those kind of cross-government collaborations before, this is something that Nova Scotia Health could not drive solutions from the top down, although they feel the burden of these high length of stay, alternate level of care patients. But it really required more of a collaborative, bottom-up type approach. And so that's why we wanted to bring in co-design. And so we started by setting these principles in place. And the first one is creating a safe space for honest conversation, because I'm sure you know that innovation can't be unlocked until you have those really crunchy, uncomfortable kind of conversations. So we need to be able to create the space where that is going to happen. Secondly, putting people at the centre, particularly patients and families, and not just using that as a slogan or lip service, but like literally inviting them to the table at every step of the journey, and hanging out with them in their homes and getting to understand and empathise. And then designing with, not for. So this means that Nick and I, as the co-design consultants, we weren't coming in with solutions. We were coming in to hold a space, create a container within which people with skin in the game, the people who are actually going to have to implement this, patients, frontline, physicians, OTs, PTs, they are the ones that are actually designing the solutions. Nova Scotia Health has this great phrase, test and try. and we really leaned into that, and we did a lot of muscle building on iteration, learning by doing, thinking with our hands, prototyping, and Graeme will speak more to that later. And lastly, we weren't just trying to solve the pinch points of today, but we were trying to understand the longer-term demographic challenges that the province is facing, the technology disruptions, skate to where the puck is going. And so we were trying to design a future-fit system, and they were our 5 principles that we used throughout the process. Graeme already talked to you about some of the different people that are involved in the process, and it was really important as part of this process to put the governance in place up front, because you will run into conflict in these kind of projects, and if you haven't figured out your governance at the time you run into your conflict, it's too late. So we had the sponsors layer, which are the people who can turn the funding taps on and off and remove the barriers that no one else can. We had the steerco, which would meet monthly. They're the executive level decision makers across the 6 organisations that would provide strategic guidance. And then the extended core team, which Graeme has talked about, that's 65 people who are the doers. And then within the extended core team, there's what I would probably call like the hardcore team, which is Graeme plus 5 project manager, comms, analyst types that were actually doing the work and driving the momentum between the co-design. So our co-design process followed a pretty standard process. Anyone who's done design, human-centered design before would not be surprised by this. This is our first year of effort. Start by framing the problem, being clear on it, like Graeme talked to earlier in terms of why we're doing this. Then doing secondary research, jurisdictional scans, literature reviews. And then in the primary research, we sent a team of 7 senior executives from across the organisations to the UK. They'd been doing discharge hubs that we thought were best in the world, and we went around and visited in a learning journey 4 of the high-performing trusts and could actually see and believe, because we could see this kind of thing is possible. And then we also did dozens of ethnographic interviews, hanging out with patients. Nick and Graeme got in a car, put on the 90s rap music, and they drove around the province and visited the hospitals, the major hospitals and sites, and spoke with frontline staff and shadowed and got to understand them. They weren't quite as hardcore as your Minister for Health here, spending 24 hours straight in an ED, but over several weeks they did get to see speak to hundreds and hundreds of frontline people. And so what we did was we took all of this research and then we synthesized it, we crunched it down into insights, and we took those insights into co-design sessions with 50 people sitting in a room, working together over 3 days to understand the problem and design the new discharge approach. And then from that, we took it into a transition design roadmap, which was really trying to build out the future pathway to implementation. And then we started prototyping, and Graeme will talk more about the portfolio of prototypes. So that was year 1. Year 2 was really taking those prototypes from the tabletop into the field, doing lots and lots of iteration and testing, and then selecting both an urban and rural pilot site, preparing those pilot sites for launch, and then building a scaling roadmap on how to take this and scale it across the province in the next 4 years, and also working on the enabling conditions, which includes policy, getting supportive policies in place, includes getting the digital layer of this working, and it also included some of the governance pieces. So that was really what we focused on in year 2. And as we did the research on getting people, it's easy to admit people into hospital. It's hard to get them home because the barriers can be so diffuse. And so we knew there wasn't going to be a silver bullet technology fix to this, and we knew it wasn't just a simple service redesign. It was system transformation. And that meant we had to think of it in terms of multiple layers. And so from the research, we identified 5 key layers of intervention. The first was around governance policy and funding. The second was streamlining process and pathways. The third was standardizing structures, roles, and accountabilities. The fourth was interoperable data and information flows. And then the fifth was the physical and virtual spaces for co-location and collaboration. So that's a little bit of the process architecture that we built to take the 6 organizations through this journey. But Graeme, this is not the typical way that things happen in government and in healthcare. So can you tell us, what did that feel like for you and your colleagues?
Yeah, so definitely there was buy-in. Like, I just want to be really clear about that. We had full buy-in from our groups leading into this work. There was direction from senior leadership to do this work at the deputy minister level for our government colleagues and at the CEO level for us in Nova Scotia Health. That definitely sets the tone for things. And yet there were bumps along the way, right? The process was difficult, and we had to alter course along the way. And so if you take a look at this next chart, I'm not going to walk you through the whole thing, but I just want to sort of show sort of the ups and downs, the ebbs and flows that happened throughout our journey over time. And we saw their varying levels of engagement shift and change throughout the life of the project. And so what we found was that we needed to have the enabling relationships that were foundational to the entire thing, right? This keyword for us, the whole theme of this talk is about relationships for me. And so those relationships enabled us to know when people were frustrated, when we were asking too much, when we were leaning into them in a way that didn't make sense, it didn't fit within their culture. And then those foundational relationships from that group that Alex was talking about, the Nova 7 we called them, that ended up, that went and visited those different UK high-performing trusts, those groups, those 7 folks enabled that sort of structured layer of relationships. And then we could find out, we would get texts during meetings, this meeting sucks, right? We've gotten that text from a senior leader within the civil service to one of us. Great. How do we fix that for next time? And so what we did is we altered course. We shifted approaches and we changed the way that we engage folks so that it would make more sense for them and fit within their demands of their team.
Yeah, I remember sometimes people were saying, like, you're not inviting me to enough of these sessions. And then all of a sudden people are saying, you're inviting me to too many. So here's some photos of the experience. But Graeme, you mentioned kind of some of the bumps on the road. Do you have like an example that you could give?
Yeah. So along the way, I had a conversation with one of the directors within the government departments, and they had a conversation with their frontline staff about how they felt this was going. And their staff comment was, it's interesting work, but this is not going to change any relationships. We're not going to see this get any different. We don't talk to each other now, and there's really nothing that we're going to be able to do to change that. And so what was great was her response to me was, I can't wait to prove her wrong. Like, she was so bought in to how this was going to shift and change the culture that we would actually truly integrate health and social care in a way that had never been done before in Nova Scotia, that would set the groundwork to enable those relationships to truly happen.
Awesome.
So another example I want to give here is just around how the dynamics played out within our different teams. So you can see here from the visual, we've tried to sort of demonstrate like the relative side. This is not to scale, right?
Actually, it's to scale.
Oh,
yeah.
Wow, impressive.
I did calculate the area of the circles.
Yeah, says the applied mathematics, right? So Nova Scotia Health has 40,000 employees, physicians, and volunteers. And then our smallest government partner, the Office of Addictions and Mental Health, has a staff of 30. And everyone else is in between. And so what we found was, this just happened just this past September, 2 months ago, we're working on this escalation management team, which we'll talk a little bit more about in a minute. And they're a group that is trying to resolve long stay cases. And we've got some cases that we can't resolve. We're the team that's supposed to fix them, and yet we can't resolve them. So we need to lean into this and figure out what's happening. Why are we contributing to the barriers to getting these patients home? And so we're like, well, let's form a working group. Let's get the group together and have a conversation about this. Some of our groups are like, we're maxed out. We can't engage that way anymore. We're tired. We have other pressures. We have other cultural issues that are in play. So we're working around that as a group. They have open and transparent communication with us. And we're like, okay, let's pivot, let's change the way we show up. So we've got a plan, they'll stay connected to the work, but they're not necessarily going to do all the development portion of it, they're going to weigh in on the back end.
Thanks, Graeme. Great example.
So Alex, so one of my roles is to really stick handle across the 6 levels of partnership, right? Having those relationships and kind of make some tough calls and push people a little bit. But as a third-party group, so yourself and Nick, who's now moved up to the front row. Thanks for that, Nick. We have a different function that we've played throughout the life of this. Can you talk a little bit about how it plays as a third-party consultant?
Yeah, and every successful transformation I've been part of has had this kind of inside-outside partnership dynamic, because you kind of need to push and pull, and there are strengths and limitations of either role. So, I couldn't do the internal stick handling that Graeme did, but what Nick and I could do was act as kind of like a Switzerland. I'm not saying we're completely unbiased, but we're neutral enough that we could create a space to have some of the more sensitive conversations. And one example of this is when we identified the biggest risk for health beyond hospital is, let's say we actually succeed at this and we get a lot more patients discharged a lot faster with higher needs into community. And what happens if the home care support system isn't there to catch them? Then the whole thing could backfire. So we were directed by Steerco to set up a working group on this. The only problem is that, as with is very common in government, when you've got a rub point between 2 organisations that's been going on for years, the natural tendency is kind of finger pointing. So that had eroded quite a lot of trust around this issue. So it was hard to even bring people together around the table. So we did a few things to try and set the stage where we could build trust. The first thing we did was we didn't just frame it as, home care's a risk to the hospital system. We said there's also a risk in the other direction. What if the hospital system is over-prescribing and that completely overburdens the home care? So we had to look at the issue from both perspectives. It was also important to set up a co-chair for this, somebody from the home care side, somebody from the hospital side, so that it could balance out the leadership dynamic. The next thing we did was we went a lot slower than we wanted to. Graeme and I have both been pushing, and Nick, we've all been pushing to try and make this happen as fast as possible, because these windows for transformation only have a certain duration. But you have to also move at the speed of trust. And so this working group was really slow and quite painful, but we had to give everyone an opportunity to contextualize the information, to make sure it wasn't finger pointing and adding to the blame cycle, but it was actually working towards that. And so having open, transparent drafts, having everyone the ability to comment, and anyone could join the working group that wanted to, that was how we kind of got through it. I'd love to say that led to kumbaya and everyone trusted everyone. That is not the case. But we built enough trust, and we also continued to pivot, as Graeme mentioned earlier. What we thought we were going to produce from that, which was like an open, public, current state and future assessment, that was not going to work because there were still remaining sensitivities. What we did do instead was we spun this out into an existing home care modernisation process and then embedded a HPH representative in it, and then they had the trust to take it forward. So we got the outcome we needed, but we had to be flexible in how we got there. Another thing that we were able to do as external consultants was to accept risk and to be early adopters. We didn't have 7 layers of approval to try things. So Nick and I, unlike Sean Boots, we're not AI vegetarians, we're omnivores. I still do a lot of my design process, old school, sticky notes, manual by hand, but I also feel like the only way to really understand AI is to use it and to invite AI into the room. And so we've been doing that and experimenting with that throughout the process. And so this is something that we were very transparent about, and we used it to digitize, transcribe, synthesize, both in real time in workshops, but also taking processes that would have taken weeks and crunching it down to days for getting rapid reports back to people and maintaining momentum. We did lunch and learns with the Nova Scotia Health on AI, and we saw, because of our ability to adopt this fast, an increasing comfort and use of it, always with the human in the loop. Okay, Graeme, so I'm sure people are eager to know, like, what have you actually achieved?
Yeah, so we'll share some updates. So our pilot just went live last Monday. So we're on day 7 of our pilot launch. We have discharged 6 patients home with our new process. We're super excited about that, and it's lots of good learning. But I do want to share some about the journey as well as some of the things that we've done to date. And so what you can see here is just a quick snapshot of the different prototypes. So we used a system design approach, as we referenced, which led through our co-design workshops and the prototyping. And so the prototyping process was really about taking thin slices of those bold ideas that were captured in the co-design workshops, and then translating those into different tests of change, right? So that really matched well with our test and try philosophy, as Alex said earlier. And so I want to give you an example. So all told, we did 37 different tests of change through the 8 different prototypes, which means multiple iterations towards that final product so that it could get better and better and better. But I'll give you one quick example. So our intake form was something that was intended to consolidate 6 different intake and referral forms that we have within our system into one. And so the goal there was to have this sort of finished product that everybody's willing to use, that everyone will sort of accept this digital version that we're going to share with them. We're not doing paper anymore. We're not faxing it. Like that's not happening anymore. So that required engagement with over 20 different people through 20 different iterations. So we're now, I think, on form 22 of our intake form, which is now built into our electronic medical record as a template, and people are populating that. So it's really been an interesting process for us in how that iterative work has happened. And through that journey, what was really cool about it is by engaging people in the prototyping, it actually helped with their readiness. And that has been a really interesting learning for us, and that the people that we prototyped with are higher, earlier adopters of the application of the pilot stage than most of the others. This is just a quick visual. I'm happy to chat with anybody later on if you're interested in sort of in the minutia of the model. Really just to simply say that in the darker color there on the right, our Care Nova Scotia hub has 2 core constructs, a hospital discharge team, which is centralizing all referrals that are coming for patients who are being discharged from the hospital who need some kind of support when they go home. And then it works together with our community coordination team on the community side to deliver that service. But I'm happy to talk about this more with anybody else in the future. We created a service delivery framework. We've built a ton of policies. We've done a ton of documents. Our service delivery framework really was something that was important for us to do to capture what is the philosophy, what's the language, how are we describing this? And then because of that, we were able to actually develop and generate our training and orientation tools, which have been used to deliver that to orient new staff members so that we can go live using a similar approach. Because the goal here is 13 different rollouts across 13 regional, tertiary, and quaternary sites in Nova Scotia, but all the same model, all the same structures, all the same data points so that we can have rolled up data into our dashboards, but done at a site level way that makes sense for them and enabling the relationships. And so finally, within our escalation management team, this is a group that I mentioned earlier. So it's a senior group of leaders who are intending to resolve long-stay cases that are stuck in hospital where it works outside of policy or where no policy exists. And so what we've done so far is we've had 24 cases brought forward. We've resolved 11 of those. Some patients are with us for 100 plus days. One gentleman was with us for 7 years, and he thought he was going to die in hospital. And so through this work, we were able to help resolve the barriers to get that person to the place where he's going to call home, which was long-term care for him. So our average length of stay for this group is 764 days. So they're typically in hospital for close to 2 years of the 11 cases we've seen. It took us about 67 days to resolve it. We're tracking our time to resolution. We want that to be faster. We want that to be under 30 days. We believe that we're still contributing to the problem at this point in time, and we're open about that. In terms of hospital expenses, this is a return on investment of $4.3 million. That number's a little fake, and I want to tell you about that honestly. So that is the true cost of each of these patients for an additional year if they stayed in a hospital bed for another year. There's When they get discharged, there's a patient that comes behind them. So it's not a true cost savings, and it costs money to discharge them home. So we're still collating some of that data so that we can have a true sense, and we're going to use the Netherlands model of the Dutch breakthrough method to help really look at how we generate bureaucracy-free money by resolving some of these types of cases. But the real value is in the 528 bed turns. By discharging those patients, and based on the average length of stay of 7.6 days in Nova Scotia, we generate flow, we generate opportunity for more patients to get admitted, which helps downstream from the emergency department when they've got patients who are stuck that are boarded in emergency departments, which helps ambulance offloads, which ensures that those ambulances are in the community. So it's the true complex adaptive system at play, and the real value for us is in those bed turns so far.
Thanks, Graeme, for walking us through those numbers, and super impressive results when you've only just, this is really just a prototype that actually, after prototyping, you said, why don't we just keep doing this? And so it became a thing, and it's already achieving such a return.
So Alex, we've talked a little bit about the what, we've talked a little bit about the results. Can you talk a little bit, I mean, we're at the Open Data Summit with the GovMaker group. Like, we've got to talk about data, intelligence. Can you talk a little bit about how we've used that with Health Beyond Hospital?
Yeah, sure, Graeme. So we didn't adopt an open data approach yet to this. I think it would be amazing if Nova Scotia Health would. There are other areas of Nova Scotia Health that has open data dashboards. But what I do want to talk through is this digital layer. So what we did was we've mapped the charting and documenting information flows, and what we noticed is that every organisation has at least one EMR system, and several of them have 3 or 4, and none of them talk to each other, so it's not interoperable. And so we can't even identify a patient, as in, like, somebody's come into the hospital, we can't ask OSD, is this a DSP patient or not? We don't know that because we can't uniquely identify. So that's the current state. Nova Scotia Health does have a one patient, one record transformation in place to kind of consolidate. This is a long delayed, big transformation, and even when it does get implemented, its scope is not sufficient for the size of this collaboration, because it doesn't extend into primary care, let alone into the social care and the other areas. So we needed a different kind of solution, and so we did a lot of research and analysis, and we landed on having Med Access be the solution for the complex coordinated care that would happen in the hospital discharge hub. And that means that there's a single point of truth that all of the members of the team can have access to. They may have to also chart and document in their home systems as well, but this allows that information to then flow from Med Access to all of those other systems. And the other thing is, because the primary care health system uses Med Access, we can instantaneously submit this information both on intake and discharge to the primary care doctors. And when Nick and I were out in the field doing interviews, we found the average was about 2 months for that hospital discharge summary to get to the family doctor, and sometimes it was over 12 months. So that's a huge improvement in the information flow. So that's kind of the architectural view. We also have done all of the journey mapping. I'm not even going to attempt to explain this process map to you, but for every pathway that Graeme talked about, we have done the user journey, the service blueprint mapping of the information flows and handoffs to make sure that no patient falls through the cracks as they go through the system. And then we are also doing we've built a data dashboard. We have a data working group, and that group has brought together representatives from all the co-lead organisations, and for the first time has put all of that information on a single Tableau-generated dashboard. Each of those rectangles you can click through and get real-time data on the holistic view of Health Beyond Hospital. Okay, Graeme, our time is up. We are going to wrap it up with your lessons learned.
30 seconds, we swear. So the key thing, and we've talked about it all through it, is the relationships are key, right? So underpinning this whole thing, Nick and I, when we were traveling to 12, 13, 14 different sites, I forget what the number was, visiting with all those different people, what we heard consistently was that relationships are not in place or relationships are fractured. I don't know who to talk to. So it seems super logical that the relationships are the key to fixing that. That's our first one. The second one was designing with citizens. The ability to do that work in partnership with patients, families, caregivers, having them at the table in doing that work, and then centering the entire co-design process as we plan those bold ideas. That was just super logical. That was a huge takeaway for us, and it was really important. And then thirdly, change is super hard. We talk about that Nova 7 group that went to the UK. They really created the foundational structure for that change to be able to be happening. And I truly believe this quote. And what I'll add is that never really doubt that a small group of really thoughtful and dedicated citizens who have a common vision for what they want for the future can change the world. And so we've really realized that, and we're really thrilled about what we've done so far.